Welcome back to Diabetic Foot Files, the podcast where we do real talk about saving limbs. I'm Dr. G, and today we're going to do something that is a little hands-on. I wish I was able to tell everybody to get felt padding, but this is practical, customizable, and cost-effective technique for offloading. And remember, offloading is key. And it may be low tech, but when done right, felt padding can be a complete game changer, especially for pressure redistribution and plantar ulcer offloading and gait stabilization. So, first of all, let's get into the real of it. Why does offloading matter? Before we talk about felt padding, we need to revisit why offloading is a non negotiable for wound healing. Pressure is the root cause of most plantar diabetic foot ulcers because of the repetitive trauma, the poor biomechanics, the neuropathy induced gait abnormalities, the limited joint mobility, and unnoticed friction or shear forces. So, the plantar aspect of the foot, especially the metatarsal heads, the hallux, and the heel, bear most of the load, especially in a rigid diabetic foot. So without proper offloading, granulation halts, callus builds, skin breaks down, infection enters, and healing fails. And that's where felt padding becomes an accessible, modifiable solution. So, what is felt padding? Felt padding is a compressible, adhesive backed wool or synthetic fabric used to redistribute plantar pressure by offloading at the wound site. I remember the first time I saw felt padding, definitely in podiatry school. Thought it was really cool. It's definitely like arts and crafts, so you would like it. So typically, it's available in like 1/8 inch, so that's like about 3 millimeters. I like the really, really, really thick ones that are like a 1/4 inch, like 6 millimeters. There's wool felt, foam felt, there's blended forms, there's adhesive ones that have adhesive backing and ones that have non-adhesive backing. And then there are pre-cut shapes, or you can just customizably scissor it yourself, right? Like, not, you know what I mean. Use the scissors to cut out the shape, trace it out with a pen or pencil or a marker, and cut it out with scissors. But the basic principle of felt padding is you cut a relief cavity or aperture over the ulcer or the high pressure area. The surrounding felt absorbs the pressure and the wound center is pretty much spared. So think of creating a pressure donut, okay? So that the wound isn't compressed during ambulation. And the bonus is the material also acts as a shock absorber, so it reduces the peak pressures and shearing forces. So the biomechanics behind felt offloading. Remember we talked about pressure mapping in our head. So foot pressure mapping shows that the metatarsal heads, especially the first metatarsal head and the fifth metatarsal head, carry high peak pressure during gait, which is when we walk. Rigid hammer toes, equinus, and hallux limited worsen the pressure concentration. And patients with peripheral neuropathy don't feel small injuries caused by stress. So felt padding shifts the ground reaction force, the GRF, away from the wound, helping reduce pressure up to about 60 to 80% in localized zones and promote redistribution along more resilient areas like the midfoot or the heel. So when paired with the proper shoe gear, let's say a post-op shoe or a rocker bottom shoe, felt padding is highly effective and discreet. So evidence-based tips show that study shows that combining felt padding with a removable cast walker gives similar outcomes to a total contact cast with greater patient tolerance. So it is a great alternative, especially for those non-compliant patients or the patients you cannot do a total contact cast on or do not have it because total contact cast can be a little expensive and sole padding is a very inexpensive tool to get and you can get a huge roll and be able to use it. So, supplies. So, let's get some felt padding sheet. Get it probably off of Amazon. Sharp scissors or scalpel. I've seen some doctors use a scalpel to create the donut. It much might be easier, but don't cut yourself. It'll hurt if you do it the wrong way. So keep it on a nice stable level ground when you're trying to cut the circle if you're using a scalpel. Use sterile gloves and hypoallergenic tape and a marker for outlining. So quick steps for application. So you have pretty much just tracing and cutting, okay? So remember those little what's it? Those sheets of paper, those parcel sheets of paper that was like see through that you were able to trace out things. You can do that when it comes to high pressure points with the felt padding. The felt padding is opaque, so you can't see through it, okay? So cut a piece slightly larger than the target area of high pressure. Use a marker or a template to trace the ulcer location. Then make sure cut the aperture like a donut or oval size, okay? Right over the wound site. Do not put yeah, okay. We'll get into it, but if we had a a video, will help. So make sure clean and prep the area. If there are people who are very sensitive to adhesions, like tape or anything that's like glue-like, you can use a skin tape barrier. They have wipes for that. Then you can apply the padding, stick the felt directly over the plantar surface, aligning the aperture so the hole with the ulcer, and secure with hypoallergenic tape around the edges if needed. Because sometimes people sweat a lot. Sometimes people walk so much it slides. Unfortunately, that's the patients that like walk a lot, and then it'll get flattened very easy if the patient walks on it a lot as well. So you will have to change it and then dress the wound inside the felt opening before securing the shoe. But I like to dress the wound first and then put the felt padding. That's one thing I do like to do. And then apply your external shoe gear. That's supposed to help redistribute pressure as well. So whatever your choice is, a post-op shoe, a cam walker, offloading sandal. um, Let's not do offloading sandals, okay? For padding, I don't like that. So I do love me some double layer felt. I do double layer the felt because the thicker the better. But you have to make sure also when you put the felt padding on the patient, make sure that when you're done, see how the patient walks. Because if you notice that, let's say ulcers on the medial first met head, right? You put felt padding doubled with the aperture underneath the first metatarsal head, right? And then you see the patient whole entire foot is tilting lateral because of the foot padding, right? It's redistributing it. Then you might need something like a lateral wedge or a medial posting for realignment. That's think about that. So let's do a quick clinical case study. Let's call him Mr. Jones. So Mr. Jones is a 65-year-old male with type 2 diabetes, peripheral neuropathy. He presented with chronic ulcer under the second metatarsal head. His size is 1.2 centimeters by length and zero point 0.5 centimeters by width. The wound is stalled for 4 weeks despite enzymatic debridement and foam dressing. Wore normal sneakers inconsistency. And we see that a lot. So we introduced quarter, felt pad, 1/4 inch felt padding with the aperture over the ulcer, offloading the shoe with a rigid sole, and weekly padding changes. So after 3 weeks, the wound reduced in size by 40%, and pressure readings show via insole sensors showed that 65% of the pressure dropped underneath the second MTBJ. And then within 8 weeks, the patient was fully re-epithelialized. And so what is the key takeaway with this? The wound didn't fail to heal because of the dressing. It failed due to pressure, which is a big thing that we always have to address when it comes to wounds, okay? Well, in 2014, in Advanced this is a journal. In advances in skin and wound care showed that felt padding significantly reduced peak plantar pressure. And when combined with a removable cast walker, healing rates were comparable to a total contact cast. Gabby has an idea today. So in 2019, a review in the Diabetic Foot Journal stated that felt padding reduced healing time by 30 to 40%, especially when used appropriately. High patient compliance due to comfort and low profile. Okay. So real world validation is that clinics in resource limited settings rely on felt padding as a primary offloaded tool when total contact cast is unavailable. So, what are some of the common pitfalls or troubleshootings that we get when it comes to felt padding? So, felt padding, poor adhesion on moist skin. So, honestly, you should clean the skin with alcohol to make sure it's extra dry. Unfortunately, to protect the skin barrier around it. Make sure because honestly, it can tear the skin if it's put on too long. It can shift and move if you're putting improper aperture size, like saying that the hole is too small, so that would create more pressure, or if the hole is too big, and that would cause loss of support of the aperture that's supposed to support the ulcer. And then friction, if not secured well. So if it's not secure well, you will see the felt padding literally shift over the entire wound. And that's not what we want because it can be an occlusive and trap more moisture in that edge. Okay. And then edges of that felt padding can curl and trap moisture, so it can cause maceration. So also think about that. Maybe you could add ginger violet along that area to protect the skin integrity as well as the skin adhesion barrier that can help. So other fixes, reinforce the edges with medical tape. That's really good. Use a hydrocolloid barrier underneath the high friction zone. And then educate patients to keep it dry and to have the felt padding replaced every 3 to 5 days. It is not suitable for deep, heavy, exudative, like draining wounds or infected wounds without a physician oversight or high weight bearing heels unless it's modified by a wound care specialist. So the key takeaway is felt padding is pretty much one of the unsung heroes of offloading, but with the right proper technique and patient compliance, it can take an ulcer from stagnant to healing within weeks, not months. And best of all, it's affordable, it's adjustable, and we can repeat it. It's very, very cost effective. So takeaway is felt padding redistributes the pressure around a diabetic foot ulcer, used for slice cutting and anatomical placement, combined with offloading shoe or boot for maximum effect and replace regularly and monitor for skin breakdown. That's a big thing. And felt padding is especially useful in an outpatient setting, home health setting, or low resource environments. So if you think this episode was very helpful for your practice or your care routine, share like with a friend, a caregiver. And remember, healing starts with pressure relief, not just products. And this is Dr. G. It's almost midnight. And take care of your feet because they take care of you.